Halloween, everyone. We'll get started in a moment, folks. Thanks for joining us today. We'll give people a minute to get on the call. All right, I'm going to get us started because I think we have lots to talk about today. Welcome, everyone. For those of you who do not know me, my name is Rebecca Penn, and I'm the project manager for the National Safer Supply Community of Practice. And it's my sincere pleasure to be hosting yet another Research Spotlight webinar. We have, this is our second one actually for October. There's a lot of program evaluations and newly published research that's happening these days, which is very exciting, of course. So today we will have the evaluation team from the Thunder Bay Safer Supply Program talking about their research findings. But before we get into that, let us please start with an acknowledgement of the role of colonialism in our past and in our present. So we come together today in this community of practice from across Turtle Island as people who live on treaty lands and ceded and unceded territories. Our team and community of practice members are comprised of individuals and organizations from across Turtle Island. We're all treaty people. We work in a sector whose goal is to address social and structural harms. We recognize that the production of these harms comes from our colonial history and its enduring practices, institutions, and ways of thinking in our ongoing daily lives. We know that Indigenous people, as well as members of the African, Caribbean, and Black communities, are disproportionately harmed and criminalized by drug policies that are rooted in racism and colonialism. Colonialism is with us today. We are committed to working in ways to transform racist and colonial institutions and practices to repair harms, prevent future harms, and to work towards a more inclusive and equitable future. I'd like to encourage you to say hello in our chat. You can let us know where you are joining us from. And yeah, let you do that in the chat. So today, some housekeeping. We are recording this event and we will be sharing it on our website. We'll pop a link into where you can find that during the webinar. You can enable closed captioning. We only have those available in English at this time. The session today will start with a presentation and then we will follow up with a discussion. During the presentation, if you have questions that you'd like to ask our presenters, you can pop those in the question and answer box, which you can find in your Zoom bar there with all the different options there. So just click on the Q&A, put your question in there, and that flags it for us when we get to the discussion. Otherwise, it gets lost in the chat. I do want to give a shout out to Tanya and Katie, who are joining me here to help things. That's Katie and Tanya. They are here to support moderating the chat. They'll share some links with you that you might find useful. And yeah, big thanks to Katie and Tanya. I will be asking people to complete a short poll. Oh, Abigale and Brittany and Mark, I didn't tell you this. Just after the presentation, I'm going to pop up a quick poll. Please complete the poll for us. It helps us with our stats and helps us talk about why we need ongoing funding to support the work of the community of practice. So please do that for us. Next, I just want to say a quick word about who the community of practice is, who we are, and what we do. So we are, our focus has been to support the implementation of safer supply programs But over the past few months, we've moved to a broader goal of trying to promote an accessible, evidence-based continuum of substance use healthcare, upon which Safe Supply is one tool in the toolbox. We've got almost 1,800 people from across Canada and also international members, I must say. And what amazes me the most about this community practice is the breadth of identities that are reflected, just different disciplines and different people with connections to this work. It's pretty incredible. We have a number of activities that we do, predominantly capacity building and knowledge exchange. We offer support to clinicians who are providing a safer supply or other approaches to care across that continuum of substance use care. We do program support. We offer these webinars and try to bring people together to discuss ongoing topics within this area of work. Our next webinar happening in November is a hot topic webinar, and we're going to be having, whoops, sorry about that, a number of folks come to talk about rebuilding workplace substance use health policy. And I hope you'll join us for that webinar. It's November 21st, and it's happening at 2 p.m. Eastern that day. Usually we do it at noon, but that day we're doing it at 2 p.m. Eastern. And we do have a certificate of attendance about halfway through the presentation. We'll pop that into the chat so that you can access the certificate if that's useful for you. If you need one aside from that time, please just contact me. And just again, a little plug, if you're not already a member of the National Safer Supply Community Practice, please consider joining us so that you have access to our resources. Yes, and otherwise, our website has a lot of different resources that are available to everyone and anyone, including an evidence brief, a whole page that lists a number of program evaluations that the report from today's presentation will be joining. We also have a YouTube channel that you can access from our website, and with over 50 different webinars that are available for you to watch. And don't forget that our website also has a resource library with a number of protocols and policies and clinical guidance documents, as well as peer-reviewed academic literature and other reports. And with that, enough of me. Let me stop sharing. And I'm really happy to be turning this over to Abigale, Brittany, and Mike. And I'll let you introduce yourselves and take it from here. Thanks so much.
Great. Thank you so much, Rebecca. I'm always so impressed with all of the knowledge mobilization that's done through the community of practice. And we're really just thrilled to be here to be able to talk about the findings of the program evaluation in Thunder Bay. So I'm just going to pop up our screen first, and then we'll kind of jump into who we are and what we've done. So Brittany, do you want to give a shout out to say hello to everyone?
Hello, everyone. My name is Brittany D'Angelo. I'm the Director of Mental Health and Substance Use Programs at NorWest Community Health Centers in Thunder Bay.
Great, thank you. And I'm Abigale Sprakes. I'm a faculty member with the Faculty of Health and Behavioral Sciences in the School of Social Work at Lakehead University in Thunder Bay, and have partnered with NorWest Community Health Centers in order to do this program evaluation and some ongoing research. And we will be joined later by Mike Baker, who is another member of our research team, who will be able to talk about his role within the team and really why we wanted Mike to be part of that. But I'll let Mike talk to that when he comes. And so Brittany and I are just going to, I have control of the presentation. So Brittany, I'll turn it over to you to get us started.
Thank you, Abby, and thank you, Rebecca, for your initial land acknowledgement. I'd like to take a moment to recognize Thunder Bay's land. And for those of you that don't know where we are located in Northern Ontario. We're on the northwest tip of Lake Superior, and it is a 5 to 6 hour drive in either direction to the next biggest city center. So the land on which we provide our program is the traditional land of Fort William First Nation, signatory to the Robinson Superior Treaty of 1850. We're also a hub to many other Northern Indigenous communities. Some of them are remote fly-in communities, and some of them are driving distance to Thunder Bay. It cannot be ignored. I'm going to welcome Mike very quickly. Hello.
Hi. Sorry for my tardiness.
All good.
But,
So it cannot be ignored that many of the disparities that we see, including the disproportionate number of Indigenous peoples struggling with substance use, is a direct result of colonization and the ongoing intergenerational trauma and marginalization of Indigenous peoples. We as a society have a collective responsibility to address this injustice. Next slide, please, Abby. So a little bit about why we pursued a safer supply program here in Thunder Bay. We do have an opioid overdose death rate that is 3 times the provincial average. So it's the highest in Ontario and the second highest in the country next to Vancouver. In 2023 alone, we had 259 confirmed opioid overdose deaths and many unconfirmed deaths. We, as many of you are suffering from a toxic street supply. We know that we're finding fentanyl in drugs such as methamphetamines and cocaine. We're also finding synthetic opioids in with fentanyl, and we're seeing many different cutting agents, including xylazine and other veterinary drugs. And on average, our monthly drug testing results come back with around 60 to 65% of drugs coming back as unexpected. So something other than the individual thought that they were purchasing. Next slide, please, Abby. So here at NorWest Community Health Centers, we work on a philosophy of care that substance use occurs on a spectrum, and that spectrum can go anywhere from no use to recreational use to use that is harmful to somebody's life. And that we have to have the programs and services to meet clients where they're at. So we understand that just as it is important to have treatment and recovery options, it's also incredibly important to have harm reduction. For when folks are actively using substances to help improve their life and keep them alive.
if I could interject in that, and many of us are diagnosed as with polysubstance dependency or substance dependency, which makes us just disabled people, and we have a human right to not be denied our healthcare or medical treatment of these things, of what we based on because of our disabilities.
Yeah, it's incredibly important that we don't look at drug use as a moral failing, but understanding that it is something that we can help folks with a harm reduction approach to be able to use in a more safe way. Thank you for that, Mike. Next slide, please, Abby. So a little bit about our program model here in Thunder Bay before I hand it over to Abby. We do work on a client-centered model of care, so clients are involved in all decision-making regarding their care. We do have an NP-led model. The main medications that are safer alternatives that we prescribe are Dilaudid and using Cadian and methadone as the backbone. We also provide a full primary care scope of practice and system navigation, so we can help with anything from housing to identification, to financial and legal aid. And we also work incredibly close with our partners. So the Safe Consumption site that's located in the same building as the Safer Supply program, as well as the other interdisciplinary care that we have in our community health center and many of our community health and social services. And then we also have developed through this program an advisory of people who use drugs that help inform program decisions and guidance. Next slide, please, Abby. And of course, we have our steering committee that has helped with the implementation and guidance of our program and advocacy for our program. It includes many other organizations that are here in Thunder Bay and region. And we'll pass it over to Abby to talk about our evaluation results.
Great. Thank you so much, Brittany, for providing the context of Thunder Bay and also of NorWest Community Health Centers. And great to see you, Mike. Thanks for being here. So I'll just kind of start off a little bit with our research and evaluation team. And you heard Mike already talk about this as coming from a human rights perspective, and the evaluation team wanted to ensure equity and diversity as well for leadership for people with living experience. And so Mike, as a research assistant with us and an individual who has been accessing medication through the Safer Supply program, and Mike's role has been integral to the success of this program evaluation. His leadership leadership has kept us on track. His leadership has kept me in line to make sure that we are coming at this from all angles with respect, dignity, and from that human rights philosophy underpinning harm reduction. And so again, Mike, just want to acknowledge all of your wisdom that you brought to the evaluation. The 4 names you're seeing underneath Mike's, these are master's students that worked along with Mike and I as well to work through the evaluation to make sure that it was fulsome and a meaningful report. I want to also just thank all of the knowledge sharers that we talked with, all of the individuals who are part of the Safer Supply program in Thunder Bay that participated in the research, of course, the staff who welcomed us, and sometimes it's tough with a program evaluation around what are people, going to ask and how are they going to go about it, and trusted, the philosophy that we were coming to look at the evidence and respected everyone who was accessing and utilizing that site. We also had a people who use drugs advisory committee and a steering committee that Brittany has already spoken to that helped guide not only the evaluation, but oversight of the program as well. I want to take a moment before we get into the results, and I know you're interested in that piece of it, but the way in which this report has been laid out has been intentional. And the inclusion of people who access this life-saving medication that's part of the Safer Supply program, we try to include at every point along the way. And so, and I have permission to share names as well. I just want you to know that as well. So William was the artist that did created the cover art, and he created art throughout the report. Will was asked, if there was an image or something that came to mind that when he thought about what the Safer Supply program has brought to his life, what that might be. And this was the painting that Will did, knowing that it was to talk about the Safer Supply program and, of course, the turtle. And we're on Turtle Island. And we asked Will, why the turtle? What does this mean to you connected to this program? And Will said it's a place that represents, it's a safe place where you're treated with dignity and respect. And went on to say, the program saved my life. It stopped me from reverting back to my older ways. Safer Supply makes my daily life easier to deal with. And so you're going to see this turtle image time and time again, because we want to remind everyone when they pick up this report that these are people's words, their voices, their wisdom, and you're going to see that peppered throughout this full report as well. One of the other things I want to mention before we go on, and this is written in the report, but I feel like we can't talk about positive outcomes without acknowledging people who have died as part of the opioid crisis. And so we wanted to reflect on those lives that have gone too soon. We cannot discuss life-saving measures designed to address the opioid epidemic without first acknowledging the individuals who have died as a result of the toxic, unregulated drug supply in Northwestern Ontario. We recognize the grief of families, friends, and communities that have been forever changed by these deaths. We recognize the outrage I always get emotional with this. The outrage at not having timely or enough services for those in greatest need. And we recognize the profound loss that communities have endured due to this preventable epidemic. And finally, we recognize the mobilization of their grief into compassion and advocacy to prevent deaths. So we won't forget those who are no longer with us, and we're going to work collectively for solutions. It is also not lost on us in Ontario what's happening to this program. So we're going to talk about really positive program evaluation results based on evidence, knowing that we are living in a time right now that this program and the people who are in it are in great jeopardy.
Abby, Mike would like to add something.
Oh, sorry, Mike, go ahead.
Just that I don't know if it's been established or if the other members here today are aware that not a single program participant has died while actively using the program as a result of overdose, and I think very few have even had any overdoses, let alone critical ones.
Thank you, Mike. You're like reading like the ahead on the next slides. It's like
Oh,
no, it's perfect though. It's like perfect timing. Brittany's already given you context of where we are and who we are, and maybe the only other point I'll make again is just the disproportionate impact. So out of the deaths that have happened within Ontario in 2023, 13% of those deaths happened in Northern Ontario, and we're only 5% of the population. And so when we're thinking about life-saving measures that's required in order to address the opioid epidemic, you know, quite clearly we can see that there's a need in Northern Ontario, as there is across Ontario. But again, we want to look at that disproportionate effect, especially when we're talking about impact of colonization. Some more numbers for you. So Brittany talked about numbers of death during the evaluation period. This was an 18-month timeline that we looked at for the evaluation. And within that time, according to the Chief Coroner of Ontario, we had 120 deaths in that 18-month period, 108 which were confirmed and another 12 or so suspected. That number has actually grown during that time period, but at the time of the report, it was 120. In that first quarter of 2024, Thunder Bay was around 69.5, which was deaths per capita, so per 100,000 people. So again, Brittany mentioned these 35 people. That's who we're talking about today. A small program in Northern Ontario that has worked with 35 individuals who have not died during their involvement with the program, but knowing that there were many deaths around the program during that time period, and that can't be lost in this evaluation either. So the goal and vision of the program, very similar to many others across Ontario and Canada, but essentially to reduce deaths and harms related to the toxic drug supply for individuals with opioid use disorder, to be able to have prescribed, regulated, safe opioids in a supportive care environment, which really has led to greater stability and wellness while addressing those social determinants of health for the overall quality of life. And I'm going to talk to you about 4 specific findings that actually speak to the goal and the vision of the Safer Supply program directly. You've heard a little bit about our research team, but just to give you an overview of the evaluation framework. And I want to just, I don't know if they're on the line or if are on the line, that's me dating myself, the telephone, that are on the webinar, but we reached out to the Ottawa Safer Supply evaluation team when we were starting and said, can you share? And Patrick and Marlene said, absolutely. So if they're here today, thank you. If they're not, I'm sure they'll see this. But this just goes to show the collective impact of the National Safer Supply Community of Practice, where we're all working together to really amplify how important this program is. So the 18-month period was from October 1st, 2022 until March 31st of this year. That was our evaluation framework. We worked with all of the people you've heard about already to create that logic model. We did do a mixed method design and of course received REB approval due to the sensitive nature of the topic that we're addressing. So what did we do? We we reviewed chart data. The chart data was incredibly helpful in understanding people's change over time, all de-identified data. We did surveys and we talked with clients that were currently on the program, but we also talked to a subset of clients that were part of wraparound services that you'll see in the report, but you won't hear about that today. But we wanted to see what was changing for people who weren't prescribed a safer supply of opioids, but were still getting access to wraparound services to improve their quality of life. And so we talked with those individuals as well. And then we did 30 semi-structured interviews, 20 with current clients, and then with staff as well. So that's how we got all the information that I'm about to share with you now. So here's a high level demographics. So out of the 35, almost 50-50, we had 50% of individuals identify as men, and so about 18 and then 17 identify as women. 66% self-identify as Indigenous, and then you'll just see on the screen there age of onset and then age the clients currently are in the program now. So you just can see the longevity of use for people who are currently participating. What is this slide? So this one we looked at how long had people been in the program, and this actually becomes a really important slide when we look at the findings. So what you're seeing on the top, the blue with the numbers in it, those are people who are currently in the program at the time of evaluation. So for instance, October 22 2 people came in, they were still involved with the program 18 months in. Anyone who's turquoise are individuals who are no longer in the program, who have discharged for various reasons, gone on to another program perhaps, relocated to a different community. None of these are discharges from the programs. These are all people moving on to other things that they wanted instead of being on the Safer Supply program. That line that you're seeing there is our 6-month mark. And what we found is that individuals who remained in the program for longer than 6 months experienced our 4 key findings that really are about the social determinants of health. These are similar to findings across other programs. So we're adding to the evidence around the effectiveness of Safer Supply programs. So we specifically found that the individuals in the program had decreased risk, and I'll get into that, increased basic needs being met, increased health, and increased connection. Peppered throughout the report and today's presentation, I'm going to bring in the voices of the individuals involved with the program and read those to you as well. So this is from CRN. This program is the best thing that's happened in my life. It saved my life. I would probably be dead already if it wasn't for this. Decreased risk. So Mike talked to this a little bit already around the level of overdose that was happening prior to people coming into the Safer Supply, and then how that has decreased with, again, highlighting that there has not been any deaths. So the 3 months prior to individuals coming in, this is a collective count, there was 130 overdoses that were reported for individuals before they came into the program, as opposed to 10 that occurred over an 18-month period. So 130 3 months prior, 10 over 18 months. And so right away, we're hitting kind of like the goal of the program, evidence around a 92% reduction in drug poisoning events for individuals in the program due to getting access to Safer Supply. Decreased use of fentanyl. And so we're talking, of course, about fentanyl use from the street that's contaminated, that's unregulated. And we see, almost 26% of people who are no longer using fentanyl because they're able to access the Dilaudid. We're seeing a decrease in use. So 80% positive change in fentanyl use, decreasing, less risk. Mike, this is one area that I know we talked about in our community webinar that you were able to speak so well to, but around decreased risk, we noticed, of course, that people had 100% reduction in withdrawal symptoms. So that's not to say people weren't still experiencing withdrawal symptoms, but the excruciating pain from the dope sickness that people were experiencing, there was an overall reduction across the board. We saw then as well 100% cessation in crystal meth use. And so that became curious. We wondered about why that might be the case. And then in other areas of stimulant use, a reduction in crack use, and then a cessation in crack use as well. And I'm wondering, Mike, before I go on in the slides, is there anything that you wanted to mention about why it might be that people would not be using crystal meth or be reducing their crack use?
Well, typically when you go to you call it a trap, it's I'm sure I don't know if everyone's familiar with the term, but it's one of these seedy locations where we go to buy our street drugs. They sell crack cocaine as well. It's it's a one-stop shop, I guess, and it's very similar to would you like fries with that? And we're being addicts is hard to share, and we're gonna buy what's there. And I think that could be a reason. That's one of my reasons.
Availability.
Yeah, it's availability.
Yeah, thank you, Mike. I think that's so important to recognize that when people are removing themselves from the traps, because they're having the opioids from the Safer Supply site, that they're not then getting the crystal meth or the crack cocaine that's also contaminated from the traps.
And one other point too is the fundraising, we decided to call it the illegal fundraising, whether it be shoplifting, the sex trade, theft in general, or robberies. People are no longer, people involved in the program are active users, are able to either decrease or completely eliminate these activities, which can lead to depression or bring on, the feelings of that we are self-medicating for in the first place. It's I'm sure many people are familiar that drug use, just like alcoholism or even eating disorders, can be just a self-perpetuating cycle. So if I don't, say for example, I were a thief, which wasn't my thing, but I'd feel guilty about having to steal and or run from the store, and even if I'm not using my methamphetamine anymore, or sorry, or my which yeah, we because drugs go hand in hand, and if, like I said, we have less in the perpetuating aspect of things to self-medicate for it. A lot of us are using the opiates, the Dilaudid to stop the withdrawal, and the crack cocaine is, for example, it's something to get high with. And when we don't need that reason, we don't have that reason to self-medicate, we don't.
Thank you for that.
Yeah.
That's a theory, and that's one of my reasons anyways.
I think that's really helpful to kind of share that perspective. So thank you so much. And I know one of the other areas that we've looked at as well related to this is because, as Brittany said, there's more comprehensive care through this program, that for individuals that may need some of their mental health supported, that if they were able to get a prescription of Ritalin or Adderall, that also then was decreasing people, self-medicating through some of these substances as well. So there's, I think, a couple of reasons around why we're seeing this decrease. And so that's again helpful. And Mike, you are on point again around where we're headed next. And so really that decreased criminal activity. And I think one of the things that Mike's been able to really point out is the ways in which people fundraise. And so some of those fundraising activities create more risk than others. And so of course we see similarly over time that as individuals are involved with this program, they are doing less and less fundraising that leads into criminal charges, being in conflict with the law, all of those types of things. So when people then became in the program, we of course saw a significant increase around their own kind of safety, but also I think safety for community, because that gets brought up as well. Jason, and the amount of money that I was having to come up with every day was unrealistic, even probably was a job kind of thing. So I was out daily boosting, stealing, not just once, but 2-3 times a day to get frickin' fentanyl or crack, to be able to be normal functioning towards the end of the day. And the next morning, the whole thing would start over again where I'd wake up sick. And Jason is certainly someone who talks about not, needing to do those things in order now to kind of move on with his life. And so, again, just really powerful statements from participants. Increased basic needs. So one of the major findings, I think, of this report, in addition to safety, is about housing. Thunder Bay, as well as many places across Canada, is in a housing crisis where we do not have access to safe and affordable housing. And so we again saw individuals coming into the program where they lacked housing, where many people were sleeping outside, couch surfing, living in encampments and shelters. And once becoming involved with the program, you can see that these statistics and the percentages almost flipped into reverse. So before Safer Supply, 71% of individuals lacked housing. After involvement with Safer Supply, we see almost 74% of people housed. And I think this is a really important slide to pay attention to when we're thinking about social determinants of health, and the things that this program does over and above, also being able to provide a safe, regulated prescription. And so when you look at the housing, though, one of the things I'm going to talk about later is connection. And I think what's powerful about this slide is that housing isn't always the traditional, I find an apartment, I find a room. Some of this was about family members inviting their loved ones back in. So because of their level of stabilization, they would say, come home. come for the weekend. Let's see how it goes. And one person shared an example of living in an encampment and a family member saying, I have a heated garage. Why don't you come there? Why don't you try this and we'll see how it goes? And like really powerful and meaningful for individuals to be able to make those family connections in a way that wasn't happening, of course, before. So you'll see this kind of playing out in a slide a little bit later. Of course, increase access to food and services. So the site itself provides food, but also a number of food banks. People are required to have ID in order to access them. So the access to services was things like getting IDs, being able to do advocacy with other services that perhaps individuals had maybe a history with and they weren't comfortable re-engaging. And so again, we see through these staff relationships that people are having access to increase services in order to meet the variety of needs that individuals have. This is GD. I was homeless till about a month ago. We had a tent, and even though it wasn't heated, we had a propane heater. It was one that converts into a home, so I wasn't worried about poison, but yeah, it was getting hard here. You know what I mean? Yeah, like because we have to come here or come there twice a day for the first bit, but now I have an apartment and a job lined up. And so again, we just see the trajectory of people's lives when there's some stabilization and healthcare provided. Increased health. This is two-tier. This is both mental and physical health. Of course, we saw an increase in physical health. People were stabilizing on the safer supply. They were having their primary health care needs met. Immunizations are occurring. The management of chronic diseases is occurring. And so we see an increase. We saw something interesting too around a decrease. And so we were curious about what that was about. And some people talked about the fact that I actually didn't know I was as unwell as I was before, but now that I actually know I have this condition, I actually feel like I have decreased health, even though I had it before I didn't know. And so people talked about it in that way, like the knowing actually led to, oh, I'm really more unwell than what I realized. And so they do talk about being able to get the support of primary care in order to address it, but that knowing piece plays out a little bit in our decrease here. And so immunizations as well, we see an increase for people who didn't have immunizations before. We also see, again, people being able to address chronic health conditions. I want to mention just the 100% engagement in HIV and Hep C care. Within the Hep C care, I think right now the program has an 80% recovery rate with Hep C at this point. And so again, things that wouldn't have happened necessarily before. We also see a decrease in emergency room visits. And I'm not convinced that this is a great stat. I think in Ontario, oftentimes we measure community-based practice on number of visits to emergency room departments. I think I'd actually prefer to see this number increase so that people can go and get the healthcare they need when they need it. But what individuals talked about is experiences of racism within the healthcare system, experiences of extreme stigmatization around drug use, but even more stigmatization related to being on the Safer Supply program because healthcare practitioners are really not understanding the level of prescription that people were needing when coming into hospital. And so again, I'm not convinced the 50% drop rate is a good thing. I'd like to see people actually using the healthcare system more for their needs. So from Jason, just recently, one type of down, so fentanyl, started to cause my feet to swell out, like how they were before with my legs having really bad abscesses on my leg. Like I probably even almost lost one leg. So probably within the next couple of months, if I wasn't on this program, I would have had health problems like that again. Mental health. So again, same story, right? Increased mental health. People were talking about feeling connected with staff members. They were talking about reconnecting with family and friends. They were talking about getting support for past traumas and being able to have places they could go and not feel judged when their trauma was showing up in behaviors, and not being judged for those behaviors, but being welcomed with care and concern, and expecting people to be living difficult and having hard times, and being welcomed in with open arms within the program. So the mental health, we're seeing an increase as well. Feeling like people more in control of their life, decreased daily stress. And of course, people are still feeling at times not in control, and there is stress, but they're seeing decreased days of stress, right? And increased days of control, where I feel like I can handle this, whatever this might be in their own life. Viola. I would say that I'm more energetic and more happy. Sometimes everyone has their days, but I feel like I'm just more happy. I wouldn't be able to do this without the program, like getting off everything. I wouldn't have been able to do it, not even in treatment or detox, because I do not feel safe in any of those places. And so when people talked about mental health, they talked about safety and they talked about connection. This is in the report. I'll just leave it for a second and keep going. But when we talk about the services that happen over and above just the care related to substance use and wound care is not here because that's an ongoing piece that happens in the program as well. But out of 35 individuals, you can see the access to care that they're getting through this program. Last finding that I'm going to share with you, increased connection. So before being part of this program, the majority of people felt really disconnected from the community. After involvement, people said, I can actually walk down the street and look someone else in the eye. I don't always feel like they're seeing me through a certain lens of stigma, because I'm feeling like, I have some stability. I'm going to some place where people care about me. People use words like, I'm treated like a human. Again, going back to Mike's point about human rights. I feel seen, I feel worthy. And so these connections just permeate throughout the evaluation. Another really powerful one connected to family. So once involved with the program, a 46% improved relationships with family. And I just think about the people that I talked with around how that was the thing that made the difference for them, that I can talk to my auntie, my mom, my children, that people are able to have conversations. I can have conversations. I'm invited to things. I can participate. Just a real shift. An increased relationship with friends, although this one was sort of interesting. People said, there's some friends I'm not sure I want to have those relationships back with. I'm looking for different people maybe, or maybe people from my past that I remember having good relationships with. So, or some people just said, like, I actually haven't had friends until I came to this program. So the people who are here are my friends. They're my community. And I haven't experienced that before. So the power of that kind of collectivism that's happening as well within the program and creating a community of care was also something that came through here. It saved my life, got me back in touch with my family and friends and in the good graces, and I'm helping doing things for my family and not doing crime. Things are going smoother. So those are our 4 key findings that you'll see in the report. There is a lot of content in the report, but one of the things that I heard sort of in the periphery is, and I've been doing this work for a long time, so I'd heard this even before doing the evaluation with Safer Supply, but people would say things to me like, so what's the end goal? So people just go there and they get drugs and they can keep doing that. And I was saying, okay, well, let's go back to the evidence. What's actually happening when people are coming to this program? But people are saying, well, what goals do they have? And I'm like, there is incredible goals. And I don't know that we reflect those goals back enough. So I want to take a few minutes to share collective goals. So there were some goals that you won't see because it was 1 or 2 people talking about them, but these are kind of the overriding themes. And of course, goals changed the longer people were involved in the program. So within the first 6 months of the program, these were the goals that people were talking about clearly. I'm here to stay alive. I'm here to reduce overdose and drug poisoning events. I'm here to reduce being involved in risky situations. I want to reduce withdrawals. I want to get my life back. Not sure what that looks like, but I want some control over that. To gain structure and stability. and to gain access to some other services. 6 months in, I would say goals began to change to having hopes and dreams for something else. And what people talked about then was, I want to reconnect with my family. And you saw how that happened in our findings. I want to see my children. My children want to see me. I think I want to think about working, maybe volunteering. I want to be able to contribute. I want meaningful work and purposeful work. And I might not be sure what that is yet, but that's something I want for myself. Maybe that's going back to school, upgrading, whatever that might be. Maybe I want to go to treatment. And this is just for a handful. This is not a trajectory by any means. This is, some people want to go to treatment, and they started to talk about that the longer they were in the program. Some people didn't, and that's fine too. Access to take-home doses, to have stabilized housing, to reconnect with their culture, and maybe to stop using entirely, especially fentanyl. And so when people say to me, what's the goal of the program? I say, listen to the people's voices, listen to kind of the participants in the program, because this is actually a lot of wishes, desires, hopes that they have. And Mike, I saw you kind of leaning in a little bit. Those goals are kind of something that I know kind of resonated throughout many of our conversations.
Yeah, I was just trying to read it. I need reading glasses. And
I remembered mine today.
Yeah.
Okay, so I'm gonna briefly show you these as well, because you'll be able to see the report. But of course, with anything, there are strengths and challenges, and that's also true for any programs where we're trying to deliver service to people to get them what they need. And so I think maybe there's a couple of things in here that stand out. One of the bigger challenges, I think, is our care pathways. So access when people were going to hospital, if they needed a surgery or they needed care, or, they were, going to jail and that they didn't have access to their safer supply there. Or maybe they were going on to a treatment center or a healing center to address one component of their life. And so those care pathways, we know, aren't there. And so that's one of the bigger challenges that people talked about. I think people were clear, we don't want a pharmacy model because the pharmacy model, and these are my words now, but I'm kind of summarizing, the pharmacy model doesn't get us to a better quality of life around the social determinants of health. If there's going to be nothing, we'll take a pharmacy model because the safer supply is saving our lives. But in order to carry on in a way that we can kind of create meaning in our own life and have those connections, we want connection. We want connection. You've heard this if you've attended these before, you've heard this before as well. People looking for access to a fentanyl-based product, but also access to a safer supply of stimulants, so that, yeah, I'm not having to go to a trap house to get crack. Maybe there's something else, I can get through safer supply. And I know some places are doing that, and these things become contentious. But if we're talking about prescribed medication for people to live and have a quality of life, we need to talk about the full range of substances that could be available. There may be some things in here that you see that you're curious about, and we can maybe leave those to a question period at the end. So throughout the research as well and the evaluation, there were overall themes that stood out, strings that kind of came through many conversations in a number of areas. So you've heard me use the word connection many times. The work that the staff do at this program, and I know many other programs across Canada, is life-saving work, is connection, is meeting people where they are at in a way that I have not seen before. And I've spent a lot of time in this program now and other programs. The importance of having people with lived experience as part of a staff group is critical, that clients talked about as well, that it makes a difference in their life to know that someone else has been where they are, because it also created that hope and those goals, and being seen as role models, and really being vocal about their own experiences and not standing behind that wall of professionalism. But yeah, I've been here, I know what it's like, and that really made a difference. And the again, words of human, worthy, I matter, all of those types of words just came through time and time again. Housing, you saw the slide connected to that. So I'm not going to say too much more, but also the need to see safer supply within primary care, that this is a chronic health condition. And so if substance use becomes a part of healthcare, that will help also to destigmatize the society that we're currently living within. And I know there's much work to be done there, but that was what participants were talking about throughout the evaluation. Addiction is trauma. The evaluation was trauma informed. We didn't get into people's trauma stories, but what became really clear is that, of course, addiction itself is trauma. That experiences that people have while they're living with opioid use disorder, while they're living with substance use, that having withdrawals, having naloxone used, even though we know it's life-saving, still traumatic, the experience. Maybe we're not talking about that enough for, people with living experience to tell us about that. Death of family members due to the opioid crisis, death of family, death of friends, across the board, and their own kind of worries. So addiction as trauma. Diversion. Certainly we asked about diversion, and we asked about, why do you think people might divert? We know that this is one of the hot topics that often gets brought up in the media. There's a certain narrative around this, but I can tell you from the people that I spoke with in this program that they are fundamentally themselves concerned about diversion, because they know the risk diversion runs around, if this were to happen in our community, this program might no longer exist. And we'll talk about the program no longer existing. This evaluation was done at a time of where we're talking about sustainability, not closure. So diversion was in the context of compassionate sharing, self-medication so that I don't have dope sickness, or that might be the reasons. Maybe people might divert to meet basic needs. And so these reasons around why that might happen, but very clearly around compassion. And so that's a narrative that we've talked about even here many times, but that it isn't getting the same, of course, it's not getting the same airtime, I guess I'll just say that. And so it's a topic that we talked about. This last area around future, this is a really hard slide, the next one, because again, when we were doing this program evaluation, we finished it, into June of this year, and we were, wanting to have conversations with the feds around, what does sustainability look like? We have the evidence. What is that like? And so questions were asked in that context. Questions in the evaluation were not asked in the context of, if the provincial government comes along and closes this program. So I just want you to have that context, because the next slide is about the themes that came out time and time again around how people felt pre-Safe Supply program, during the Safer Supply program, and sustainability. So people's emotional state, their connection with others, their overdose frequency, and the probability of life or death. So people went from feeling hopeless, alone, high overdose rates, thinking that their lives may end, to hope, feeling supported, low overdose frequency, and thinking about life. Sustainability had people worried because they were like, I just don't know. I don't know what the future is going to hold for me if this program doesn't continue. And we're here now. So the report was not meant to bring us to this place, but we find ourselves here. And I just really want to, again, acknowledge everyone who's on the line, who is on the line again in this webinar, in this Zoom call right now, that's impacted directly. And just, again, really acknowledge, Mike, you coming and being part of this webinar. Again, I just can't say enough what you've brought to this research. Shiz. It honestly makes me want to cry thinking about them, politicians, taking it away. I just, honestly, that just looks like my whole world collapsing.
Add something to that, Abigail. Is that they're not only are they going to be closing the Safe Supply, but they're also taking the safe injection out at the same time. And a lot of us are using less, or if not no fentanyl at all. And a lot of us are fearing relapsing back into the hardcore fentanyl use. especially the diversion, like you said, it's compassionate sharing. Most of those who divert, I know for myself, the times I've diverted, it's not about getting money. It's because I know my friend is trying. If I give him a couple of dilaudits that, and he knows that it's regulated, it's specific. What he every time he's gonna, if he cooks up the same amount, he's gonna use
Yeah,
the same
thank
amount.
you. Yeah,
And
thank you, Mike, for sharing that compassionate sharing piece and why people might. That's really
but
cool.
even
And I
with
think
us,
the other piece, sorry to just cut you off, because I think I just want to highlight something you said that's just really important. That again, NorWest is the provider of the consumption and treatment site in Thunder Bay, and we know that, of course, this has huge implications around the provincial government. And I wonder, Mike, if we can jump into the advocacy and amplification of voices, because I think this is exactly what you're trying to do right now. Would that be okay?
it's not necessarily, hold on, it's not necessarily about the diversion. So even ourselves, like when we're not getting this, we will likely go back to using fentanyl, and we're not going to have the safe place to use it, and our tolerances are going to be different. We're not, some of us aren't going to be as familiar with what's going around, and it's just dangerous. We're not going to have that safe place to experiment with that again if we go to it. I know many of us are considering um, alternate routes such as methadone or whatever, and but I'll let you continue. I just wanted to
No.
add yeah, the safe consumption being closed at the same time, and
Yeah,
that's
no,
which
thank
gives us the fear of the future.
absolutely. Yeah, we can't really talk about one topic without the other, so I really appreciate you bringing that in, because again, yeah, we know the implications that has for many communities across Ontario, but specifically in Northern Ontario. Thunder Bay in Northwestern Ontario is the only consumption and treatment site available, and so the impact that you're talking about, Mike, around how else might people stay safe, knowing what's what might be happening. Um, So the other area that we looked at was, and I called it advocacy. So these are my words, advocacy, but really the amplification of voices. And we asked individuals as well. And Mike's doing a really great job of this right now, kind of raising the concerns. But what would you want to say if you had, a politician or a key decision maker in front of you right now, that you could tell them about this program or how important it was? So a couple of slides on that. So James, I say it's a safer alternative, like Leslie to like sorry, like less likely to overdose. Some people want to get off the down, like the pills are helping to stop using down, they're helping. Nathan. I feel like I matter now. Yeah, I feel like I matter. And Nathan was getting quite emotional at this point and said, I'm just not another statistic. WP. We're people too. We need this program. It's saving our lives. It saved my life. I'm still here because of this program. Shiz. It does more good than harm. Taking it away, it's going to cause a lot more fallout. If you think there's a problem with opiates now, take it away. Do you see what that does? Like, it's going to cause like a big domino effect. All those people that got better, they're going to be back on the street. And just, you know what I mean? It helped me and just changed my life. So just that would be devastating. Viola. My city, so Thunder Bay, is struggling and we need the support. I would like everyone to know that the program, not only helping us clients, they're also helping the city as one, like my family. Like I would say my family, because they're getting me back. Yeah, they're getting back the person I was before. So they're definitely grateful too. I hope that this program just doesn't stop, because I think that will just cause more problems. And for me, I won't have my support system. Yeah, it would be tough. It would be tough. And I really hope it doesn't happen, because I need them. And a few last words that we asked again, people, what the program meant. And you're seeing again encapsulated here what you've heard throughout the report. and where do we head next? Because there has to be a next step. So part of what we're trying to do is continue to amplify the voices of individuals who are directly impacted by the opioid crisis. So not only people within the Safer Supply program themselves, but those people who would like to be in them, family members, community members. We're doing webinars, presenting at conferences, and the release of the report that's happening today. I've also been supported in a next step through the Canadian Research Institute on Substance Matters to delve deeper into the lived experience of individuals on the Safer Supply program. The other research we're doing, which is fascinating right now, is we've been supported through a community engagement research grant that is, we're engaging in digital storytelling related to the importance of the site. And we've just started that. We've just finished up our storyboards. And those will be 2-minute clips from people involved with the Safer Supply program, talking about the importance of the program so that we can, again, put some faces, some names, some words, some heart, some value behind a lot of the statistics, behind the evidence. And so we're right in the middle of that right now. And I'm using those as advocacy efforts to continue to keep this conversation alive, and maybe in ways that other people can't at this point. That is one of the benefits of academics, that we can say things that maybe others can't. And so we're going to keep pushing this forward, saying the evidence demonstrates that this program saves lives. We've seen it time and time again. And I'm going to say that ideology here is impacting people's lives, and we have the evidence to make a difference. And I'm going to stop there because we've got some time to chat. If you have questions outside of the webinar that you'd like to ask, or things you're curious about that we weren't able to kind of get to today, you can connect with Brittany related to anything that's programmatic or what's happening within Safer Supply and the consumption and treatment sites. If you have questions related to the research and the ongoing evaluation, I'm more than happy to have conversations, to meet. The more I can talk about this, the more we get it out there. So I'm going to stop my share, correct, Rebecca?
Yeah, thank you so much, Abigail and Mike, and Brittany. Powerful stuff, really powerful. I am going to post the poll and ask people to respond to that. And also people can put any questions that you have in the Q&A box. I'm also seeing thanks and some really positive comments in the chat throughout your presentation as well, Abigail, Mike, and Brittany. So here goes the poll. It's just 6 questions. It'll just take you a minute, but we can continue on while people are filling out that poll. And again, thanks for doing the poll for me. It really helps me a lot. Okay, can I ask you the first question? All right. When you launched the program, there was already a lot of media coverage, good and bad, about Safer Supply. Did that make it harder to get buy-in from the community, healthcare staff, or clients? If so, what are some lessons you learned about bringing people on board?
That's a great question. I would say that the media coverage really started around the time that we were launching the program. So it was, of course, very timely. In a lot of ways, it made it more difficult to have to address myths that were not factual, or when we were seeing things in the media that weren't necessarily true of what is actually happening in the program, and then having to go address those, whether that be through presentations, through information that we were sending out, or with one-on-one interactions between our frontline staff and other community members or other providers when they were trying to support a client. The bad media coverage definitely contributes to stigma that our clients experience. And so we kind of have our work cut out for us in having to educate and go out there and say that this program works, this program is safe, this program is saving lives, and it's a human approach to substance use and keeping people alive with our toxic street supply. The good news for us was that so many others had done a lot of work before we launched our program. So the community of practice, our colleagues in London and Ottawa and out in Vancouver and Victoria had done so many research papers, guidance documents that we were able to use. So although the good might not be as prevalent in the media as the bad, we know where to go to find the good. We know where that goes guidance documents are and where to find the best practices. The lessons that we've learned from that is that we need to keep putting the evidence out there. We need to keep talking about the evidence, and we need to keep addressing the myths. Abby, I don't know if there's anything you want to add to that.
Yeah, great answer. And then the next question is about the types of medication options that are available. The specific question is, what are the pharmaceutical stimulant options that people ask for? Methylphenidate or less dexamethamphetamine. I didn't pronounce that very well, did I? Yeah, can you talk about the stimulant options and what people are looking for in regards to stimulants?
So we don't actually have a safer alternative for stimulants that we're using in the Safer Supply program in Thunder Bay. We do certainly diagnose folks who have been suffering from undiagnosed conditions like ADHD. And treating that with ADHD medication, but we haven't moved into alternative options other than opioids. So I would not be the most appropriate person to answer that.
Did you hear at all about what kinds of medications people might be interested in having? Be it like, are people happy with Dilaudid as an option? And then some of the backbones, Cadian, methadone, or are they looking for, like, those are the ones we typically use, and there are very good reasons for why we use those. Largely, like, that's what's available to us, right? Either because of the Ontario benefit formulary or whatnot. But the constant question we have is whether the medications that we are able to prescribe and people do have accessible to them are they meeting people's needs and wants?
We certainly hear that clients want access to fentanyl-based products. We know that fentanyl is more potent than Dilaudid, and that when folks are using the street supply of fentanyl, which is incredibly potent, that we're not able to get the same effects from Dilaudid. And we've also had folks bring up wanting the ability to smoke their medications. We've seen a big shift from injection use to smoking fentanyl. And then the other thing is if they don't want to take pills orally, they want to burn down and inject Dilaudid. Liquid hydromorphone would be a great option, but the drug formularies, the concentrations that we're able to access right now end up being a very large volume of liquid for somebody to inject.
Can I add to this? Also, I've been informed that it takes 1,000 milligrams of Dilaudid to equivalent to 1 point of fentanyl. And typical, I think the maximum dose a day is 42 8 milligram Dilaudid pills, so 336. So it'd be the equivalent to 336, less than half a point of fentanyl. And many of us came into the program using half a gram of fentanyl. So if like 5 points of fentanyl, we would need the equivalent of 5,000 milligrams of Dilaudid to equivalent to that. So not only is the Dilaudid not anywhere, what's allowable is not anywhere near what we're used to. It's
just enough to keep you not sick.
It's just enough to keep us not sick.
Yeah.
Methadone. I think many of us would have been more willing, like especially if we're working for a long-term goal, maybe we could start with the fentanyl and then move to Dilaudid once we have that under control, and then so on and so forth. But
Yeah, thanks for saying that, Mike. We do have in a document that a good little graphic around the morphine equivalencies that really does a good job of highlighting just, yeah, that difference between what people are used to and then what they're getting with the dilaudid. And, one thing that I've read in other reports and heard anecdotally in in some of our interdisciplinary settings are um, people who are on the programs are, originally they came to the programs having not found that methadone or Suboxone was effective for them. Like that's actually a requirement for most programs, just in terms of triaging people, because everybody needs access to safer supply programs, but there's just not the capacity. So people come and having not had success, and they're being offered the Dilaudid, but also finding that it's worth trying methadone and Cadian as a backbone, or even a fentanyl patch where that's available and appropriate, because fentanyl patches can be another whole kettle of fish. But yes, that they find that backbone of methadone or Cadian is really, really helpful. And then having the Dilaudid for use throughout the day. That actually works for them and helps them even think about moving to methadone um, on its own or Cadian on its own. For some people, whose goal is to change how they're using, right? So yeah,
I would
interesting.
say, just to add to that, Rebecca, I mean, a number of people did in the evaluation talk about, again, having Suboxone or methadone kind of prior to, and this became the next alternative due to the fact that that wasn't something that really worked well in their life. And so people, again, talked about how the safer supply, even if it wasn't quite fentanyl based, was it was more enriching in their own lives around stabilization, to be part of this program versus trying like the methadone program. And a lot of people were referring to it as, like, feeling like they're in handcuffs, that they didn't have the same kind of mobility and freedom and things like that. So a lot of the individuals had in this particular program had tried that ahead of time. And I know people are thinking about it moving
Yeah.
forward, but that is some of
Well,
the
and it also invites some interesting questions, right? About what is it that is working here or not working with methadone? Like, was it the medication itself, or was it the model of care in which methadone is delivered, right? So it does invite those questions. But ultimately what we really well know, I think, is that different people need different things, both, different types of medications, different approaches to care. Like, I one of the things I really appreciated about this presentation was just how well it demonstrates the value of this model, this program, that provides the wraparound care, and how it's so much more than just a prescription. It is access to all those other services and primary care and all of that. It's about repairing relationships between healthcare and social care providers and people who've had been traumatized a lot in those settings and with those, professionals. Um, and I think that, it's just such an important piece there. I was gonna say something else with that, but I forgot. Tanya, you have your hand up to share a question that somebody couldn't put in the chat.
Well, it was my own, but
Or shouldn't put in the Q&A. Oh, if it was your question. Oh, go ahead. Go ahead.
All right, is that okay, or should we
Of course it is. Please.
Okay, first of all, thank you, Mike, for your lived expertise today. I thank you so much. It takes a lot to kind of be vulnerable and share our lived experience, so thank you. And thank you to Abigail and Brittany. This was one of the most, I don't know, coming from a more human lens for me in presentations. My heart feels really full right now. So I just had a question about the diagnosis of substance use disorder. I understand why we need it. I understand we need it to access certain programs. We needed to access certain things. I've needed it to get into certain programs, certain things.
but it follows us, right? So it's followed me, and it's really kept me sort of, I've had surgeries where I haven't been using for years and it's on my chart, and then they still treat me like I'm a substance user. It's still stigmatizing. It's still, and I don't feel like I have a disorder anymore. I don't feel like I'm sick anymore. I don't feel like I need this label anymore because for many reasons. So I don't know the solution. I'm sure nobody does right now, but like, what are your thoughts on that? Because it is a problem, and it continues to be for me specifically, because I have to tell my story over and over again when it's way back in my history, you know what I mean? But yet, and then I don't get the proper care because they're like, oh, you're gonna relapse if we give you opioids, and I'm like, actually, it should be my choice, but it's not still after many years. So just a question about that label.
Maybe I'll jump in, and then Brittany or Mike, if there's something you want to add to it. So yeah, Tanya, I couldn't agree more. And so yeah, you see it in the report, and yes, I couldn't agree more. And I do think you know, there's some benefits to the label around having programs available, but I don't think it's an effective way in which to engage with people who are using drugs. And so one of the things that I've seen with this program is that as individuals are coming in for an intake, it really is more of a holistic view of what is happening for the person, and that substance use is one thing, and that is what's bringing them into the program itself. But they're definitely, at least, you know, I've seen the charts, I've talked to the staff, but that label, I mean, really isn't occurring in that way. And in fact, I mean, there isn't an addiction psychiatrist. There's not that diagnosing itself that's happening, but there is some symptoms related to risk that this program is trying to address in the way that if there's kind of high risk criteria, and what I mean by that might be significant amount of overdoses, the level of use that's happening, access to care, all of those types of things, that would kind of triage someone more into the program than the label itself. More, you know, what do we need in order to deliver humanistic care to people? And so I'd say you see the label, but it's not something that is, I would say, operationalized in the sense of the day-to-day with the people in the program. And I don't know, Brittany and Mike, how you feel about what I've just said there, but that's certainly been my perspective and what I've seen in doing the research with you for the last year.
I agree. Language is so important. It's the difference between saying it's somebody who uses substances versus a person who uses substances instead of a substance user. It's putting it in a term where it's for that individual to define if it's problematic to their life. And I know I started the presentation with the substance use health spectrum, and I think that we need to educate more. We need to reduce stigma in healthcare so that talking about substance use is a normal part of every single healthcare interaction that we have, whether the individual defines that substance use as not harmful or harmful to their life, if it's affecting other aspects of their life, or if they're suffering from other things because of it, like social isolation, or being vulnerably housed or homeless. And just as 10 years ago, there was stigma around walking into an appointment with your primary care provider or the emergency department and talking about your mental health. And we've really started to normalize that. We need to normalize providers asking about substance use health when you go into an interaction, whether that's primary care, the emergency department. And as we normalize those conversations, the stigma is going to reduce with it. It's going to open doors for people to say, hey, you know what? I actually want to have a conversation about that today. Or allows them to say, you know what, I don't define my substance use as problematic, and that's not for us to say that their use is a moral failing.
Thanks for that. It also makes me think there was a comment in the chat. I'd have to scroll through to find exactly what it said, but it addressed the point of euphoria and how people sometimes are seeking euphoria, be it the child who spins and spins and spins and spins in the playground, or, you know, we do those rides, or at the amusement park, or animals that find plants that help them feel a certain way. You should see my cats on the kitchen table this morning with the catnip. Like, we are pleasure-seeking beings, and the role of substances in that, does not have to be pathologized or any of those things. I think, your point, Tanya, about these labels that do follow us around, like, yeah, how we can work past that. It's one thing for someone to choose a label to identify themselves, and that can be labels that I might think, oh, that's, stigmatizing. People are like, no, 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 that label I choose for me. And it's like, okay, I got to respect that. But it's a different thing when somebody else puts a label on me and then uses that label to determine how to treat me. And so again, I think we really need to do that work with on an individual level and then at organizational level and professional levels around again, client directed care. Like, what is this? You've got this label in your chart, Tanya. What does this mean for you? And then you can be like, that's so long ago. And I don't imagine that past history impacting my now, and then having the conversation about whether, so everybody can feel comfortable with that. So yeah, a lot of work to be done in that
And it's
regard.
and it's re-traumatizing every effing time. I have to relive it every time.
Can't escape.
We worked so hard to heal and to get past some of the stuff. And then each time we have to relive it. It just brings us a little bit back, and it disempowers us, and it makes us feel small again. And it's hard because it's power imbalance, and it's a lot. It's a lot. Other than saying, I'm just someone who struggles with trauma and I just use stuff to cope. I mean, I don't know. Let's relabel stuff. I don't know. It's hard. I understand though why it is the way it is. So just acceptance is key as well. But yeah.
I think the other thing is that, like, we have to talk about the fact that society has stigmatized certain drugs and not others. The same week that that it was announced that we're closing 9 safe consumption sites in Ontario, and we increased accessibility to alcohol by putting it in corner stores. Yet the majority of costs, like the most costly drug for taxpayers when it comes to harms related to substance use is from alcohol. So society has said it's okay for me to go drink a bottle of white wine on a Saturday night, but it's not okay for somebody to go use fentanyl to deal with their trauma, or to make sure that they're not going into physical withdrawals from this addiction that they have. And so a part of that conversation is starting to talk about, well, why is one thing okay and not the other? Why is it that we are promoting alcohol use and marijuana use, but we're saying that folks who are struggling with other substance uses is not okay, and that we're going to stigmatize that even further?
Yeah.
I just want to make one more point to that, Rebecca, just one more. So just because I had surgery recently, and it's come up, and this is why it's fresh for me. Because I thought I was in the clear because I went to a different city and they didn't really see my chart from my original city, but they found it. And then when it came time for pain medication, and the nurse specifically said, like, well, you're at high risk of relapse, you're at high risk of this and this and this, and really, and so I'm already in pain, and I have to explain my whole story and be like, I just want to be treated like every other person. Like, if I want to fuck my life up, that's up to me. Like, you just do your job and let me live my life. Like, it's such a yucky, gross thing that we all have to go through. It's not right.
I'm sorry to hear that,
End
Tanya.
of rant. I'm done.
No, fair enough. Fair enough. We do have a couple of other questions, so let's. One of them here is looking for some advice around how to talk to people who have. Well, they refer them here as the naysayers, the people with concerns about safer supply, particularly around diversion. So the question: I have been concerned with the news articles regarding a huge influx of safe supply being sold for fentanyl. Can you help me address this to the naysayers? I have a couple thoughts, but if
Well, I
you
mean,
want
I
to give
think
it a go first.
there's some realities here, and I don't know if this helps the naysayers or not because they're naysayers. But I think when we look at at least what I'm being told from the people who are involved with the program, we're not, if things are to be sold, they're not getting sold at, people aren't making a lot of money off of the lottery pills for one. So it's not like this entrepreneurial activity. But the other thing is, if we look at even, because there is a lot going out to say, oh, diversion's happening, people are, dying from diversion. I mean, if we look at the chief coroner report around hydromorphone and what's happening, we're not seeing that narrative play out in deaths. We're not seeing people dying of hydromorphone specifically. And so that would, suggest if there was this huge influx into the streets, that actually would be occurring to people that had no tolerance for that type of medication. So I think there's a reality around what's being said in that narrative, and then the reality of what's actually out there. And if I look at even the hydromorph stats from before we had safer supply programs, and that would be in combination with other opioids, we're actually not seeing the same level of hydromorphone in people who are dying of opioid related. So it's curious to me that this narrative continues when we have, again, the evidence that shows that that is not the case.
Yeah, thank you. Anybody else want to add anything?
Yeah, I think Abby hit the nail on the head. Show me the data, show me that this is happening, and show me that it's actually a problem and a risk to the community. Instead of ignoring all of the amazing data that we have showing that safe supply saves lives, that it is helping communities be healthier, it's reducing crime, it's reducing emergency department visits, 911 calls, and we keep ignoring all of those really positive, amazing things for this narrative that has come out in the media. And one of the things that I think concerns me the most is the idea of, for lack of a better way of saying it, it's the idea of throwing the baby out with the bathwater. If there were merit to what is happening in the media in this narrative that folks are selling their Dilaudid for fentanyl, the obvious solution is that we make fentanyl-based products available to clients if that's what they're asking for. And the second obvious solution is that we know that the supply is, or the demand is outweighing the current ability for us to provide a safer alternative to all of the folks that are struggling with opioid use. And so the second solution is to scale up the programs instead of shutting them down.
Cheers to that. That's the exact answer that I hear people, even talking about, like, why don't diabetics get access? Why don't people who have diabetes get access to free injection equipment? And people who use drugs do. It's like, great question. Like, let's get the people with diabetes access to free medications. Like, and I think that's the thing, is we all, instead of, exactly like you said, throwing the baby out with the bathwater, instead of, getting rid of a program that is clearly having very powerful benefits for the people who are involved in the programs, let's figure out how to make those programs better and more accessible, and address the drivers of diversion, address the drivers of substance use. Yeah. Thanks so much, Brittany. You said that really well.
Yeah, and I think something that I don't know if we're talking about enough is people who use substances have equal rights and protections under the law, under the Charter of Rights and Freedoms. And the conversation that we're having keeps coming from the other part of the community that is seeing harm reduction as a harm to the community, that aren't understanding that harm reduction is a fiscally conservative option. It's saving money. It's actually making the community safer, but it's also giving people who use substances a right to choose what it is that they want to do, and they deserve that equal protection by the law. And what we're seeing happening is their rights being taken away, and their ability to live safely while using substances is being taken away if we're not able to provide these programs and services. Safer supply and safe consumption fall in that category.
And what a perfect place to end the webinar. That's a great last thing to state. Although I do also just want to give Abigale and Mike a moment, if you also want to, if there is anything you want to close out with.
I'm good. That was beautiful. Thank you.
Yeah.
That was
Yeah, it's covered, and with the way you worded what about, everything, yeah. It was a good session today.
Thank you all
Excellent.
for
I'm
having
just
us.
so big thanks to Abigale, Mike, and Brittany. Really appreciate the presentation. We will be posting the presentation and the report on our website. The webinar, the video recording will take me a little bit to get up, so you'll find the recording tomorrow on the website. Big thanks to you all. Also, thanks to Tanya and Katie, and thanks everybody for coming. And just a last minute plug for our November 21st webinar, Building Workplace Substance Use Health Policy Using a Harm Reduction Lens. That'll be a great one as well. And if you're not already a member of the community practice, join the community practice by going to our website or otherwise just go find all our great resources on our website. And with that, I will say goodbye. Thank you for joining us. Take good care of yourselves and each other. Thank you very much for joining us.